Good afternoon, everyone. Thanks to John and Ann and Sage's program committee for inviting me. So we've talked a lot about measurement. We've heard some really great overviews on quality measurement. And I'm going to shift a little bit here and talk about quality improvement, and specifically talk about a unique experiment that we have in Michigan working with our payers to use data to implement broad-based change across the state. And I think this will just give you some overview of how to use data for improvement. And then I'm going to focus and kind of end on some of what I think are kind of cool projects that we're working on. And I know these involve coaching and video and are great interest to Sages, and Sages is starting to think about moving into these areas systematically themselves. So I think will be of relevance to this society in particular. So I have disclosures. I have grant funding from NIH and AHRQ, and I'll be talking about those funded studies in this. I'm also co-founder of a software company called Bariatric that creates software for profiling hospital outcomes. So the collaborative I want to focus on specifically today is the Michigan Bariatric Surgery Collaborative. And this is funded by Blue Cross Blue Shield of Michigan. And it's essentially a clinical outcomes registry, but really a quality improvement program. The surgeons throughout the state, all the surgeons and all the programs pretty much come together to learn from our data and to implement change, as I mentioned. And we have about 35,000 patients per year going into our clinical registry. Our clinical registry is like many clinical registries you've heard about, like NSQIP, like MBSA QIP, which many may participate in. We do medical chart abstraction, collect outcomes, and longer-term outcomes. So similar in regards to that. But I think one thing that we're really clear about is that outcomes measurement doesn't automatically lead to quality improvement. If you collect all that data and you get it from the feedback and it comes and collects dust on your desk, that's not doing anybody any good. And so we take the improvement side of this very seriously, and I think you'll see that by the end of this talk. So this is a picture of our collaborative organization where we come together, and it's really about surgeons doing our best to learn from our data and coming together around our data, and then learning from each other, identifying who's good, who's not so good, and then helping everybody improve. I'm going to give one example of a project we've done that focused on perioperative care, and that was the prevention of DVTs after bariatric surgery. As many of you who do bariatric surgery know, that could be the leading cause of death after bariatric surgery. And when we started out with our collaborative, we thought this was kind of a non-threatening thing to get involved with. It doesn't make anybody angry to talk about DVTs as much, and everyone has a different opinion on what to do. First thing we did was start and look at practices, and we saw that essentially every hospital did something differently. There were no standardized protocols in place. So one of the first things we did was put in place a standardized risk-stratified protocol for DVTs, and we implemented this statewide. Now, the only reason we were able to do that is we had the attention of the surgeons through the collaborative. And over time, you develop social relationships, and we audited it, so you could see who is complying with the algorithm and who wasn't. And that's what we did over time, and we could see that compliance improved. I think one of the key things here is actually how long it took to get to reasonable compliance, right? Like this wasn't like you implemented in 2006 and then the next year. It just took 5 years of begging and asking and auditing and calling. Like, this is hard work. It was hard just to get someone to do a simple thing as adhering to an evidence-based protocol. So that's one take-home point here, is this is hard and it takes years to do good quality improvement. And we implemented a lot of projects like that. This is kind of what I'll call our perioperative highlight reel. We were able to decrease VTE rates, and with that, mortality-related thromboembolism declined over time. We saw our complication rates decline as well. We had specific interventions around reducing SSI after gastric bypass surgery, and then we had another implementation around ED visits. You can see, and this is just a demonstration that we were able to improve mortality in our state faster than controls. But what you'll notice there is that starts to level off at the end, and it really started to level off, and we had some soul searching. We said, well, where are we going to go next? What can we do to further improve this? We think we've got as much implementation around standardizing perioperative care as we can. And that took us to thinking about, well, we need to improve the operation itself. And I think this is a sea change that's happening in surgical quality right now. Surgical quality for years was perioperative care. It was optimizing perioperative care, preoperative care, postoperative care. But focusing on improving the operation itself, I think, is a huge opportunity to continue to improve outcomes. The only problem is it's hard. And so we had launched some specific initiatives around improving technique and skill. Our first foray into this, and this was about 5 or 6 years into our collaborative experience, so we had very good relationships with the physicians, and we were able to get them to submit videos of themselves operating. And once again, it was only those social relationships that allowed that to happen. And so we did this pilot study that was published in the New England Journal a couple years ago. And what we did here was we essentially had surgeons submit a typical videotape of a laparoscopic gastric bypass. So if I asked you to submit to me a typical tape, what would you send me? Like the best one you've done in the last couple of years, right? And every BMI in every patient was 34.9. Like you could barely tell these were bariatric patients. They were so skinny. And you'd think, well, that would probably bias this toward not being able to show any differences in skill. If everyone's sending kind of an easy case that went well, I think you'll find that that's not what the results show. We had blinded peer rating, so we basically edited the videos down, and we had the gastrojejunectomy, the jejunojejunectomy, and creation of the gastric pouch as 3 technical steps, and we had them rated on their skill on each one using a modified OSATS instrument. And this is what we found: a broad variation of skill ratings. We found that these were reliable across videos. The New England Journal made us actually get second videos from a lot of the surgeons at the top and bottom end, just to show that they're reliably rated across videos. And then when they made us get raters outside of Michigan as well, thinking that may have become unmasked and there was something there, so we got into a panel of raters outside to repeat it and show that it was highly reliable. And I think that if you want to watch these videos, you can go. There was a high and a low one published in the New England Journal and the New York Times, and you can tell. I show them to undergraduate medical students, and they can tell immediately which one is the more skilled one. So it's something you know it if you see it, and it's reliable. So the real question, though, is not does skill matter, but is it important? Is this just looking slick in the OR, or does this correlate to something important? And since we had the registry data on all these surgeons' outcomes, we could do this. We divided them into skill groups and looked at their outcomes, and it was quite striking. You can see a linear relationship between skill rating based on how your peers think your skill rate is and your outcomes. And I think this is why this paper ended up in the New England Journal, because it made that connection between video peer raters and outcomes. So remember, we're a quality improvement program. And so we had this data. It's interesting. But the question is, how do you go about improving the skill of practicing surgeons? And you think about the methods that are out there. How do surgeons normally learn new things? The state of that science is pretty low. And right now we do weekend courses. If you're a surgeon, you want to learn something you haven't done before, you can take a weekend course at Cadaver Lab, and then you make it proctored on a case or two, and you go out and you do it in your practice. Now think about the robot, right? I don't know if you guys have stricter guidelines than us, but I think proctoring is 2 proctored cases for Intuitive recommends. And I was in Australia once, and somebody raised their hand in a huff and said, well, it's totally different here. It's 1 case in Australia. So I think that state is, we could do a lot better than that. Surgical simulators are not great at this. You know, they're really aimed at basic tasks and manual dexterity skills. As far as I know, this may have changed since I made this slide, but there's no high fidelity simulators for bariatric surgery. I saw some really cool stuff in the exhibit hall here, though, so this may be on the horizon. So, like all health services researchers, we went to the New Yorker for a good research idea. A couple years ago, Atul Gawande wrote this wonderful piece in the New Yorker, and his perspective was that surgery is a physical thing. It's a physical performance. And why is it that the best athletes in the world and musicians have coaches to help improve their technical skill, and we don't? We have this paradigm, which is the traditional learning paradigm, where there's a presumption where you've been learned, you've been taught, you're done. And that's like residency, right? Whereas the coaching paradigm has this fundamental assumption that we cannot, on our own, reach the optimal performance. Like we don't have insight into where we need to improve to get to be the best that we can be. And this is a total different paradigm in thinking about surgery. I think if you think about this in your own life, the master surgeons are the people who find coaching. They find that advice, they get advice, and they continue to improve. That being said, that's an ad hoc process. There's no formal process in place, and we haven't thought about how to structure such a process or how to train people to give feedback in a way that's effective. So we wrote what was a large, ambitious study to this, because this is resource intensive and we didn't have enough resources on our own to do it. So we wrote an NIH grant, and they found it innovative and funded it. So we're working on implementing this now. I was really lucky to partner with Caprice Greenberg, who many of you know is at the University of Wisconsin, and it was her pilot work at the Brigham and Women's Hospital that Atul wrote about in that New Yorker piece. And she's continued to push this forward and has developed a coaching model. She calls it Wisconsin Surgical Coaching Program. And here you can just see that her emblem there on our coach resource manual that we used when we trained our coaches. And we didn't train them how to do surgery. We trained them how to give feedback. without pissing people off. That's kind of the key thing, the key skill set. And we spend a lot of time with that, 2 full days at our collaborative meeting. And as I said, it's training, giving feedback to kind of avoid this. This slide is particularly apt since Michigan's playing Notre Dame in the NCAA tournament tomorrow night. I didn't realize that when I made it. And this is an example. One of the coach training processes we did was we had the surgeons give each other feedback, and we kind of role played here. These are actually 2 surgeons from Michigan, 2 of our coaches giving each feedback and training. We had an executive coach who helped them learn to give better feedback. And so that's, I could give a whole talk on how to give feedback as a coach, but there's a specific process and a way to do it that's non-threatening. And the key thing, the key aspect of this coach training process is that this is co-learning. These are peers coming together to learn together. It's not an expert teaching a novice. These are 2 quite good surgeons sitting down exchanging tips. So as we were rolling out this program, sleeve gastrectomy just took off and started to replace gastric bypass. And that's what this slide shows here. That this is from our collaborative data we published in JAMA. You can see that the dark line shows sleeve just going from 0 to 70% of cases. It's now up to 80% of new bariatric cases. And this was a really interesting idea because we were collecting these videos for coaching. We obviously needed to expand it to include sleeve. But you come to meetings like this and you see these sessions where people are talking about sleeve technique, and they say, well, you should do this, you should staple here, you should staple this close, you should staple that close, and I show this one staple fire of the GE junction from one of my partners, and it's right at the GE junction, and half the room, whenever I show it, gasps, and the other half is like, yeah, that's how I do it. And so there's a lack of information about exactly what matters technique, so we thought this would be an opportunity to collect that data, those videos, and analyze them systematically, kind of group them into what exactly people did and link them to outcomes to see if any of those micro techniques, these aren't like what stapler did you use, these are like how far from the GE junction, not just quantitatively in centimeters, but qualitatively. Do your peers think you're too close or too far away, and does that matter? Does that link to outcomes? And we'll be able to study that systematically. This is just an example of the instrument that we developed to do that and kind of the standard shots, and in a longer talk I'd show you each of the standard videos that we take to categorize those. And this is where we are in our program. We trained our coaches for essentially 6 months with 2 in-person training sessions, and Caprice Greenberg was absolutely central in that, as was our executive coach colleague. And then this past October we did our first video coaching program where we actually had coaches and coachees. Now I can tell you I was worried that people wouldn't sign up to be coaches. We had 15 coaches that we recruited because I needed 12, and all 15 came. Only 3 of them are academic. 12 of them are private practice surgeons from across the state, which was exciting. But I was even more nervous that no one would sign up to be coached. And we were implementing this in a stepped wedge way, so we were actually oversubscribed for our first coaching session, which was great, and speaks, I think, to the maturity and the relationships of the surgeons in our collaborative. This is just what it looks like of surgeons sitting with their coaches going over their videos using on their laptops. There's just some more shots of what it looks like. And we do this in the morning before our collaborative meeting. So some of the lessons we've learned, I think the key thing we've learned is data collection. It's important to have good data, but that's not all that it takes to improve quality. You need rigorous implementation as well. There are huge improvements you can make in perioperative care by standardizing that, but let's not stop there. Let's get involved in the operation itself, and let's improve our technique and skill together. And I'm excited to see SAGES getting more and more interested in that, and some initiatives pushing forward in that area. Thank you.